Thank you very much indeed, Mike, for that introduction. The story has been a long story. It did start at least 20-something years ago, and I think the very first time I ever introduced this idea of the theory of constraints to the healthcare system was when I was a lecturer at Ashridge Management College, and I was teaching on an MBA program there. And it was actually a rather small program. It was the first program that Ashridge ever ran as an MBA. And I was doing my normal piece on the theory of constraints. And there was a lady in the front row who said to me, "Yes, but Alex, will it ever work in the NHS?" Yes, and that lady was Avril Dongworth, who is sitting here at the front. The but was very loud in those days because she wasn't convinced, I don't think, in the early days, but has probably been, just like Mike, somebody else who's applied this across decades in the various jobs she's had in the NHS. Now, when I was told that we were going to do a book launch, this was actually a terrifying moment for me. Because they then told me what happens at a book launch. And they said apparently what happens is the author stands up on stage and reads a chapter from their book. And I thought, well, I'm not going to do that. That is definitely not going to be the Alex Knight version of a book launch. And so what we said to ourselves is, let's try and do it differently. Let's try and find a way of explaining what the book's all about by actually giving people an experience of the book. And that's what we're going to try and do for you this evening. So we have three particular parts to this evening's activities. The first actually is a bit of context about why I wrote the book in the first place. And to be honest, it came out of frustration. It came out of hearing too many newspaper articles and too many TV interviews where basically they were blaming staff in the NHS and in other hospital and health systems around the world for the difficulties that they were experiencing. And I'd spent many years working with these people, and it just didn't make sense. I was seeing great people working very, very hard to try and solve very difficult problems, and actually what seemed to be happening is everybody saying it was their fault. So what I want to do is to show you some of the analysis that we did in both before writing the book and during the writing book on what's actually happening out there in the world of health. And for me, the important part of this analysis is not only to provide some insight for people within the industry, but also for you to share with all your friends at every dinner party that you ever go to demonstrate to them that this isn't about the people who are in the system, but this is actually about the system itself that we need to change. So that's where I'm going to start. And then I'm going to call on one of my colleagues, Alex Dinham, who is going to do a chapter of the book. Actually, he's not going to read it out. We're going to play that infamous dice game with everyone in the room here tonight. A slight twist on it, as you can imagine, just to see. Yes, it will be competitive, and there will be winners and there will be losers, but we'll see how we get on with that. And then finally, I'm going to invite Stuart to help me. Stuart Wilkin, I'm sure you could stand up for a moment. Stuart is the person who helped me write Pride and Joy. He spent many hours reviewing the parts of the book that I'd written and then helped me turn it into what it is today. And he's going to help with the questions and answers session as we go through later on this evening. So to start with then, what we're going to do is have a little look at some of the recent analysis on healthcare. And, you know, in a way, the title of the book is my response to this analysis, because many people have asked me, why did you call the book Pride and Joy? And the reason why I chose that name is because that was what I was most scared we were going to lose. Everybody working in these health systems would lose the pride of being part of doing something that's so important for the societies in which we operate in, and also the joy. This is a vocation for many people, and actually it brings enormous pleasure and rewards from helping other people recover from ill health. And it seemed to me that was what was most at risk. Lots of other problems, but actually at the heart of it, let's see if we can put pride and joy right back into the middle of the agenda of healthcare. So in terms of the analysis, the summary, if you like, is I'm going to try and demonstrate how I feel that we do need to do something different. Trying harder is not the answer to the problem that we face in healthcare. Now, Mike Williams, who gave the introduction this evening, also wrote the foreword to the book Pride and Joy, which I'm sure you've all read, and I don't need to question you on. But the very first sentence that he put at the very first beginning of the foreword was, he said, "Healthcare is a fundamental necessity of all societies." Now that's a very short sentence, but it actually has, to me, has the real heart of what this is about, yes? If you look at the words, first of all, he's claiming it's a necessity. Now, a necessity is something that we shouldn't violate. But that's not enough. He then goes on to say it's a fundamental necessity for all societies. Yeah, a pretty strong statement. And what I'm going to try and demonstrate is, if you, like me, believe in that, then actually we can develop the analysis from that simple statement, and we can understand why it does appear so difficult to achieve the sort of improvements that Mike was talking about earlier. Now, if we look at this fundamental necessity, it's not for the lack of expenditure that we see healthcare expenditure rising every year. As part of the research, we've looked at many different countries and their expenditure. Now, this graph is a bit distorted because the top line shows the expenditure on healthcare of a nation called the United States of America. Yeah, and it just shows, relative to every other nation, how much they're spending. That's $1.5 trillion growing to $2.7 trillion over a 10-year period. If I take away America and you look at all of the other countries that are there, wherever you look, you see this rise in expenditure on healthcare. So if it's something that's necessary and that's fundamental, you can certainly see some significant investment in it over that 10-year period. Yes, this data comes from the World Health Organization, and they release it in 10-year buckets. And you can see just how many nations are seeing a growth in their expenditure. And you can see a country like China is growing as its own performance as a country grows. If you look at it per capita, you see exactly the same evidence. Year on year growth of spend on healthcare. Now, I think that's enough for us to conclude that actually, we are seeing quite significant amounts of money being spent on this fundamental necessity. The problem we have is that expenditure and affordability are not actually the same thing. I have to tell both my children this at regular intervals, yes? But anyone that's running any household budget knows that this is true. But if we look at this on a national or international level, what we can do is we can actually look at the spend on healthcare and we can compare it with the GDP of a number of different countries. Now, first of all, this is the growth of the countries that we were looking at earlier. And in every case, you can see a period of improving gross domestic product. And before I leave this graph, I'd just like you to take a moment and think to yourself, what happens if those lines were flat? What happens if they actually were heading in the opposite direction when I show the next graph? Because what the next graph is showing healthcare as a percentage of GDP. Now here we see GDP growing in all of these countries. And yet, as a percentage of GDP, we see healthcare growing as well. And if you look at America, for example, it's now demonstrating 18% of the total wealth of the country is being spent on healthcare. if you go into this analysis in more detail, and in some states of America, it's now over 30%. Yeah? Now, there's not much else we spend money on. There's defense, there's education, and there's various other prime expenditures of this total amount of money. And we have here a fundamental necessity taking a higher and higher percentage every year of nations that are actually growing. So you can see why I put the precursor in. Let's just imagine we were in an environment where there wasn't this level of growth. Yes? Now, I think it's clear to see that this cannot just carry on growing forever. Yeah? And this is why we see such a challenge in all of the newspapers and in all of the TV reports about healthcare appearing to become more and more unaffordable. Actually, in the book, I describe this not for a nation, but I describe it how it's playing out for a particular hospital. And you can see exactly the same effects in the hospital that we're seeing occur at a national and an international level. If you look at the articles, Health Service Journal is one of the big papers in this country, often printing statements about our national health service being unaffordable. And sometimes in this country, we feel like we're the only ones in the world that are in that situation. But actually, if you dig a little bit deeper, you see exactly the same in many other countries as well. And this is just an example. Later on, I'm going to look at the specifics of a number of different countries, just to show you how actually we can be quite proud in this nation of how effective we are at spending money on healthcare relative to many other countries. And rather than it being given such a hard time, perhaps we should just think twice before we look to other parts of the world for a solution. I also have lots of friends from Holland here, and we're also going to spend a moment looking at some of their figures, and I'm afraid it's not all good news. The expenditure there is definitely being seen as increasingly unaffordable as well. Now, if it's unaffordable, and this is something that is also necessary, then it's not surprising that people are challenging the productivity of our healthcare systems. Yes, it's actually a perfectly natural response. Look how much money we're spending. Surely there must be a penny somewhere that we can save. Yes? And so that's what we often see, a challenge on the productivity of the provision of healthcare. And when we look at this scrutiny in a little bit more detail, you can see that it's around the world. Now, I'm not asking you to read any of these slides, but you can see that in this instance we have a country like Canada, where actually the discussion is now so strong that they're saying we've now reached a critical point where providing healthcare is no longer sustainable for our nation. Now, this is a country that is actually, as I looked at earlier, has a growing GDP. It's actually quite a successful country. And yet they're still saying it's now a matter of survival. And in the text, there's talks about percentage of expenditure going from 25% to 44% in a particular region within the next 10 years. And actually, when you read on, they reckon it could take up 98% of all GDP within 25 years if the growth rates carry on as they are at the moment. Spain, whose economy is not doing so well, is also seeing a situation where people are basically saying, we're broke, we can't afford it, we're going to have to play a game of choosing who has healthcare and who does not have healthcare. We can no longer sustain it as we have in the past. So you can see the cry for productivity improvement is very large, yes? And you can understand, and this is an important point for me, you can understand why people outside of healthcare are looking at the very large numbers of money being spent and saying, surely, 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 there must be a way of us saving money in this arena. Well, let's have a go. let's see if we were chief executive of the NHS or your own country's health system, how we could go about trying to save money. One of the places that we could go is to look at that interesting topic of drug costs. Because actually, if you look at drugs as a percentage of total expenditure in healthcare, in almost every nation that we've examined, you see somewhere between 18 and 20% of all money being spent on providing drugs as part of the treatment. Now, 18 to 20% is a relatively small number. And just imagine that we were extremely successful at bargaining with all those pharmaceutical companies, yes? And we managed to persuade them that they needed to reduce their prices. And let's say our negotiation skills were so strong that we persuaded them to reduce prices by 10%. Then in the bigger picture, all we've done is gained about 2% of our total expenses. Yes? Even if we persuaded them to drop prices by 25%, it's still only 5% in the bigger picture. So actually, even though there is enormous scrutiny on this part of the budget, I think we can see that actually it's not going to solve it just by trying to save money in that particular area. Now, in the book, I play this out in what I call Pride and Joy General Hospital, and I show for a hospital which has a turnover of about £400 million, how much of it is associated with the various categories of expenditure. And as I said, I've had this checked with my colleagues in a number of countries around the world, and actually it comes out almost the same wherever you look, that's typical of the expenditure we're looking at, about 80 in 400 million in the purely theoretical example, Pride and Joy. So, how does this play out? Well, what we're seeing is scrutiny of drug costs. The National Institute for Health and Care Excellence, or NICE as you probably see it in the news, has this job of making these decisions of whether or not we can afford the new drugs that are being released into the marketplace. And time again, we see challenges about the cost effectiveness of new drugs. This one is around a breast cancer drug, and basically it's a calculation of its effectiveness relative to the number of extra months somebody would live if they took the drug relative to not taking the drug. And the conclusion is it's simply unaffordable and needs to not be issued. From the drug company side, a bit topical this one, with Pfizer in the news as it is at the moment, but their response is, this is ridiculous, and are out there slamming the UK's drug pricing plan, saying you just have to spend more. These are better drugs, they will treat more people, and you must increase your expenditure. And actually in the plan, all it is to try and not save money, but just keep it at the same as it has been over the last few years. Other popular press, another one around a cancer drug and another one around hepatitis drug. Now, the reason I chose those examples is because these aren't special drugs for people with very, very special illnesses. These are core parts of the provision of healthcare. Yes, these are illnesses that any member of society could face. So if saving money through drugs is difficult, then maybe it must be all those staff that work there. Yeah, maybe we would be able to save money by actually trimming the number of frontline staff that are in hospitals. Yes? And actually, if you look at the accounts of a hospital, you can see that, unlike the press may tell you, actually management costs are not particularly high in this industry. If you compare it with any other corporate of this size, you will see that management costs are relatively low as a percentage of total staff costs. What you will see, which is a bit uncomfortable when you first see it, is that actually most of the staff costs are made up of frontline doctors and nurses. So if you're going to go this route and you're going to try and save money through reducing staff costs, then you have to be honest with yourselves and say, actually, it's frontline clinical staff that you're going to try and save money with. Yes, you're going to have to fire those doctors and nurses to save money. Not so much in the newspapers about this. Yes, although what we do see is warnings of need for a shake-up, warnings of need for reorganisation, warnings about it can't carry on and there must be savings that can be made here. And all I would suggest is that when we read these articles, we remember that it is those frontline staff that are being challenged. So, my first conclusion, if you like, is that if we can't save money or significant money through drug costs, and we're going to struggle to save money through reducing frontline clinical staff without putting quality of care at risk, then there is a need for a different sort of breakthrough in these healthcare systems. And hopefully the diagrams and data I've shown you earlier demonstrate that it's actually a rapid need. The last thing in the world we need is a 5-year study on this. Yes? Or please not another one. Yeah? What we need is some actions that will achieve significant breakthroughs in a short period of time. Yes? We also know that productivity is being scrutinised, and we also see not many people making a real breakthrough. And this is where one of my fears around us losing pride and joy comes from. Because more and more, you see more and more articles and conversations about the only way left is frontline staff. More recent articles demonstrating in our own country 7,000 people being enforced cuts. That's just to ensure that expenditure stays the same. But I want you to look around the world with me. This is a rather difficult graph to read, so I'm going to explain it to you. But it's in America, where what they're doing is they're looking at the number of new jobs in healthcare relative to the number of new jobs in any other industry. And what we're seeing here is, for the first time in decades, the growth in new jobs in healthcare is slower than any other part of the economy and the rest of the economy. So what we're seeing is that insipid reduction, if you like, of frontline healthcare. Yeah? We also have somewhere at the front here the chief executive from the National Childbirth Trust, who was also one of the persons at the very beginning, some 20 years ago, who applied the theory of constraints in what was then her job as chief executive of an eye hospital. Belinda down the front here. And actually we can see that midwives are also in the firing line for reducing staffing costs. Now these are babies. Yeah? This is where we're not talking about shortening the life of people who've got cancer and is the drug worth paying for the last X months of their life. This is saying that we can't afford to support midwives in the birth of our babies. Now, this is another long, detailed article from America, which just shows the top 10 hospitals and the cuts in frontline staff that they are doing this year. And these are some big-name hospitals: Washington State, other major hospitals. So what I'm suggesting is this is not far away if we don't do something about it. And we'll all start to see the consequences. Now, if it's a necessity and trimming frontline costs isn't something we want to do, we also have to see what happens when you do trim frontline costs. And in this instance, I'm going to ask you to take account of actually Mike's PhD thesis, who stood up and did the introduction this morning, because Mike Actual's PhD was looking at what happens in catastrophic incidents of the failure of care. Yeah? And what is the primary cause of those catastrophic incidents. And what I was very pleased to see is he basically did his PhD using a theory of constraints analysis process. And if you read it, it's one of the PhDs I've read, by the way, and I got to the end, so congratulations, Mike, on that. What you will see is that time and time again, the catastrophic failures in care, the predecessor to it was trimming frontline staff. Yeah, overstretched staff working too hard, and in the end, something going wrong, catastrophically wrong. There's another very good international book by a man called Atul Gawande, who has done a lot of work in this area and basically repeats the work that Mike's done on a national level, on an international level, and you see exactly the same phenomena. In Mike's PhD, there were 2 or 3 things that I just wanted to point out to those of you who aren't in the healthcare profession. Because one of the things he looked at was a retrospect analysis of case notes. And there was 2, one of one hospital and then a second one across a number of hospitals. And these are some of the statistics of we're seeing now happening. 8.7% of all admissions had at least one adverse event, where an adverse event is any unintended event caused at least partly by the provision of healthcare and which resulted in patient harm. 31% were judged preventable, 15% led to impairment or disability that lasted greater than 6 months, 10% contributed to patient deaths. And also, all of these damaged productivity. I go back to my first point. In all my experience, this is very good people trying very hard under enormous pressure, and that's what is the outcome. So let's be careful before we trim these costs any further, or just trim staff costs. Another analysis that Mike showed was this was across 75,000 patient records, and you see very similar numbers coming through across many hospitals showing these sort of results. Actually, if you look at the Gawande book, you see exactly the same results around the world. Yeah? One of the things Mike teased our theory of constraints master's students with was this particular axis, 2 axes here. Across the x-axis, we have the number of encounters for each fatality, and up the left-hand side, we have total lives lost per year. Now, has anyone in the audience ever done a bungee jump? Could you please put your hand up? Mike's the first one to get his hand up. Sam Reen has. Ben at the back there. A number of other people have done a bungee jump. Well, the good news is not many people die a year bungee jumping, yes? But actually, not many people bungee jump either. It's much safer to go onto a scheduled airline or even work in a nuclear power installation when you look at the total number of deaths relative to the total number of encounters. Now, the tease for Mike was he asked everyone on our master's degree where did they think healthcare would sit in this. And for those of you who are not in the healthcare profession, then just hold on to your seats, because actually healthcare is one of the most hazardous places for us to go. Yes? Hospitals are not very safe if you look at the number of encounters and the total number of lives lost per year. Yeah? So, the reason why I put this in is to say that, once again, let us be careful about trimming staff costs. So in conclusion, if you like, you can see healthcare stuck between this rock and a hard place. Clearly a need to improve productivity, but the 2 routes that are open to us, or most often talked about, challenging the drug companies, by the way, I'm still all for that, yeah, and reducing frontline staff, actually, in my eyes, are impractical to solve the type of problem that we're facing. You might say to yourself, yes, but it must have done some good, all this increase in expenditure. You saw over a 10-year period some countries increasing by 40 or 50% the amount of money they've spent. Have we seen any improvement in quality of care? Have we seen backlogs reduced? Have we seen prices go down? and what is happening for those who aren't prepared to wait? Well, a couple of quick graphs just to point out some simple facts. This is an international standard of looking at one measure of quality of care, and that is how many people reach the age of 65. Yes? And you can see for many nations it's almost flat. There is some improvement. This is for men, and this is for women. Women live longer than men, is one of the things we can learn from this. Has the timeliness of care been improved? Well, a study looking at many countries down the left-hand side, the crosses are all areas within their health systems that have growing waiting lists. And on the right-hand side, where you see a yes, these are all the nations where there is a national waiting time initiative to try and improve things. Yes? So very common. And another quick graph showing improvement over the last 5 or 10 years. Each one looks at a period of time, 2005, 2008 and 2010. By the way, we can be quite proud in this country at our recent reductions in waiting lists compared to other nations. Has the affordability of care improved? Well, if we look at these waiting list initiatives, they tend to cost money. And this final slide here around this topic, all the nations on the right-hand side are those that have increased their expenditure per capita and have above average expenditure per capita on the top of the graph and have a growing waiting list. So even with more money, it's not solving that waiting list issue. Now, one of the things I was keen to find out was, so what are people doing? If they're not receiving the quality of care they expect, if they're not receiving it in a timely manner, what are they doing? What choices do they have? And we started to examine what some people call the health tourism market. And you might be surprised to understand that actually it's about $10.5 billion US in 2012 on people leaving their country and going somewhere else and paying for it themselves to receive treatment. Yeah? Put it in proportion, that's about 10% of the NHS budget, where people are picking a choice to go elsewhere. And if you go into the details, where are they going? Well, Asia and Thailand, Singapore and India are the main beneficiaries of this type of influx of healthcare treatment. And it is not all cosmetic surgery. Actually, India is one of the fastest growing countries for treating coronary heart diseases and heart bypass operations. And they have a higher success rate than some of the best hospitals in America. Yeah? And the price is about 1/3 of it is in America. That includes the airfare there and back. And this just starts to show some of the beneficiaries of it. Inside Europe, if you look at this graph, the bottom part is by country saying, yes, I am prepared to have my treatment outside of my own country. And you can see various degrees of people in that country saying they're willing to travel to solve this problem. Yes? So actually, mobility of healthcare is a growing phenomena. So what can we conclude about this? Well, my conclusions are really quite simple. There is a rapid need for a rapid and sustainable breakthrough. Yeah? It's necessary and it's increasingly urgent. For many countries, it's being compromised more and more on a daily basis. Even the wealthy countries are not immunized from this. If you look at the list of countries I've shown, some of these are with the fastest growing GDPs, and yet they're still running into a difficulty. Yes? At this point, I'd just like to add one point from what Mike said. He informed you that the book is about the theory of constraints, and the theory of constraints was developed by a man called Dr. Goldratt, who I was lucky enough to be mentored for most of my career, actually. Over half of my life he was my mentor. And Ellie always used to say something to me every time I was asking for his advice. And his number one advice was always, never allow something important to become urgent. Now, because he was an Israeli, he gave a particularly Israeli explanation of this comment. He said, if there's a hand grenade in the room, it's important. If the hand grenade pin is out, it is becoming increasingly important. But it only becomes urgent when nobody knows where the pin is. And my suggestion is we're not far off that if we don't find a different way. Now, in the book, Pride and Joy, I didn't want to look at this at a national level. I wanted to bring in the everyday struggles that doctors, nurses, and managers have dealing with the things that I've been talking about. I wanted to bring it to life with those good people trying hard in all of the places that I've worked with. And if you look at it at a hospital level, it's actually much easier to sort of grasp hold of what people are struggling with each and every day. Everywhere people want to be part of a successful and flourishing hospital. Yes? In order to do that, the data is telling us that we need to improve the quality of care and we need to improve the timeliness of care. And in order to improve that, most of the cry is for more frontline staff, more frontline resources, more doctors and nurses. However, on the other hand, if we're going to be flourishing and we can invest in all of the new techniques we want to find and want to do all the research and development we're interested in, then we also need to find a way of being financially stable. And when you've looked at the numbers that I've shown you, time and time again, the answer seems to be you will have to reduce frontline staff. Now, one of the things that Dr. Goldratt taught me is when you're faced with this sort of conflict, you should not seek a compromise. You have to find a true breakthrough. You have to challenge some of the assumptions that are in this diagram that I've got up here. You can't get away with adding a little bit more resource here or trimming a little bit more resource there. Trimming a little bit of resource everywhere is the most dangerous thing to do. Yes? In these systems, what you end up with is nothing but horrendous wandering bottlenecks everywhere. Yes? It is the most stupid response possible. So, if we are going to have a solution, what must we do? Well, the first thing we must do, clearly, is improve the quality of care and improve access to care. We need to do it in a manner which doesn't just throw money at it, and we need to do it quickly. And we need to do it without demanding everyone works harder. Now, Mike talked about our very first piece of work back in Oxford all those years ago. And actually, when he was there, he was running two hospitals. One was the Oxford Radcliffe, and another one was the Horton, which is about how many miles? 15 miles? 20 miles? 25 miles up the road from Oxford. And having looked round the Radcliffe, he asked me to get in a car with him and go up to meet another group of people in the A&E department up at this other hospital. And so I had to put together a presentation in the back of the car driving between these two hospitals. And what I created on a flip chart about 20 years ago is what we lovingly call the blob diagram. Some of you have seen this many, many times before. But for those of you that are new to it, it's an attempt to show just how seemingly complex these healthcare systems are. What you see across the middle is some of the standard steps of a healthcare system. Patients arriving in an ED department, some of them going home, others going into assessment units, then going home, others going into the acute hospital, some requiring rehab, some requiring long-term residential and nursing care. One of my new young colleagues this morning asked me, "What's the white circle at the end, Alex?" He was young and he was new. Now, also you can see many arrows in and many arrows out, yes? And when you start to look at this, it can appear as if, how the hell do I improve such a seemingly complex system? Where on earth do I start? Yes? If you think about the size of some of these organisations, a London hospital will be bigger than Hewlett-Packard Europe. Now, down the back of the room, I have a man who used to try and improve Hewlett-Packard Europe, yes? And that's one hospital is about the same size, yeah? So, the purpose here is for us to see if we can find a breakthrough across this sort of environment. Now, again, I'm leaning very much on Dr. Goldratt's principles here. The first one is stop looking at the parts. You have to improve patient flow, and you have to make that the primary objective across the whole of the healthcare system. It's pointless trying to improve each part of the system. Secondly, you need to focus. If you try and improve everything everywhere, you will end up probably making things worse. One of the things I had to say to Mike in the early days was, Mike, my understanding, I think if I get the numbers right, you have 27 improvement initiatives running at the moment. Would you please cancel 26 of them? Because they're doing harm and not good. You're basically improving parts of the system that don't need improving. You're probably trying to save money, and you're going to turn them into a bottleneck if you're not careful. The other point is any solution has to be patient-centered. Yeah? I'm certainly fed up of listening to the news, hearing solutions that are going to come in from outside, that at the heart of them don't focus the effort around coming up with an idea that basically puts the patient at the heart of it. One of the reasons I wrote Pride and Joy is for the second point. The heroes in Pride and Joy and the heroines in Pride and Joy are the doctors and the nurses. Linda just has to manage the ship during a transition. Actually, the true leadership has to come from clinically led activity. My job is to drag doctors and nurses over to the dark side of management. Yes, and to get them to realise that they can do a very good job of it if they get engaged and involved. Yes, and that's very much core of what we've written in Pride and Joy. And finally, we have to eradicate, not reduce, eradicate all of those local performance measures that are around. And basically, what I do in Pride and Joy is take this dilemma. The first thing I do is show why quality of care, timeliness of care, and affordability of care are not disconnected. They are all driven from the same basic dilemma. And that is the challenge between improving both the quality and the timeliness and the affordability at the same time. We can't come up with individual solutions for each of them. In the second part of the book, which is where Stevie arrives, we carry out analysis and try and demonstrate exactly what's happening in Linda's hospital through this. The third part is the sort of yes, but it ain't quite as easy as it looks in the theory. Yes? Linda tries to go out and persuade people by telling them what they need to do differently. Yeah? Just after she's gone through the process of 3 days of learning it and undiscovering it and analysing it for herself. She learns the very difficult lesson that Linda has to look in the mirror, and if she's going to solve this, she needs to stop telling people and she needs to go back and just be Linda and face up to that is the way of engaging with people to make this change happen. In the middle part of the book, chapters 10 to 16, what I do is talk through the emergency department, the elective department, the outpatients environment, mental health, community, and many other parts of healthcare, and show how everything I've talked about tonight can be applied in those environments. Of course, it's a story, it's a novel, yes, so you have to have a twist, yes? So the latter part of the book looks perhaps for a new role for Linda and a new... Oh, some of you haven't got to the end, so I'll shut up. I won't spoil the ending for you. And the final chapter was just chapters was actually written for some people who are running healthcare systems around the globe to give them a very safe and simple way of trying some of these ideas out without taking imprudent risks. So that's the first part of this evening's activity, and a very quick overview of what the book is all about. What I'm going to do now is we're going to have a play in the book. We're actually going to have an indulging exercise, which I'm going to call on my colleague Alex to come up, and he's going to put us all to work, I think.